So today's conference is complications of cancer treatment. So I tried to pick some things that you guys may see here at the VA or things that you might run across over at the U or other rotations. And so it's a bunch of mini cases that we'll go through. If one of each of you could just hit got it on the Zoom, so that way the box is gone about the recording, we'll jump in. So case one, we have a 45-year-old female. She's been diagnosed with AML and she's being admitted for treatment. She will be starting 7+3 induction therapy. So your first question is figuring out what is 7+3, what tests do you want to order before she starts chemo, and then what are some complications that you'd worry about for this regimen. And so take about a minute or so, work through those questions. You can use whatever resources you want in terms of the internet or each other. And then we will come back together and we'll have table 1 answer what is 7+3. Table 2 will do what test you want to order. And then table 3 here at the end, we'll say, what are you worried about in terms of complications of this treatment? Yeah, 7+3 is 10.
Whatever the thread is, we should get labs for like Allergenic.
CBC provides right? So we don't
Yeah, let's bring us. Cytarabine plus some second.
Do you need a technical for that? Or because that was a pretty
And you're supposed to do a bone marrow examination 2 to 3 weeks after the start.
I just Google and but I can see the recommendations.
Okay, let's come back together. So table 1, can one of you tell us what is 7+3? You know that 7+3 is 10, but that's not treatment for AML. So what does that mean?
Can I ask a question first?
Yes, feel free to ask a question. Oh, look at that. So you want to know her cytogenetics, right? Let's say she's FLT3 negative.
So I'm going to say this severity and anthracycline.
Perfect. So 7+3 is a chemo regimen where you get an anthracycline, so daunorubicin, doxorubicin, idarubicin, any one of those that your system uses, and then anthracycline. And Josh A points out that maybe if we're really advanced and we're on our heme service, you might ask and say, is this patient FLT3 positive or not? Because they would get an additional agent for their treatment if they are FLT3 positive. But we will not jump into that. It's a little more advanced than our quick talk. Middle table, what tests do you want to do for somebody who's coming in for 7+3 chemotherapy? An echo, perfect. Why do you want to get that?
because one of the things can cause a cardiomyopathy, the one of the group is anthracycline.
Perfect.
And then just like standard labs, I don't think that these cues are going to cause like they're not checking inhibitors for like a pneumonitis or a hepatitis, but it's good to keep track of it, that any of those chemotherapies can cause that.
Yeah, excellent. Yeah, so basic labs always helpful, and the real meat of this question is getting that echo. So someone's getting an anthracycline-based chemotherapy, they need to have an echo before they start chemo to get a baseline assessment of their ejection fraction, because a cardiomyopathy is a complication of this treatment. And that can happen down the road from their exposure. So having a baseline is useful. Table 3, what are you worried about in terms of acute complications for somebody who's coming in and getting 7+3?
Might expect with a lot of nausea, vomiting, yes, dehydration.
Yeah.
Kidney function.
Perfect. Anything else that you guys would be worried about? Yeah, myelosuppression. And what was the second part of that?
Just more susceptible to infections.
Yeah, so infection. That's the main thing that blood cancer patients face anytime they get chemotherapy. All right, excellent. So we're doing mini case style. So we're just going to zoom on through. Hospital day 5. She's admitted. She's on her 7+3. The nurse pages you and says, hey, your patient has a temperature of 100.5. All of her other vitals are stable. She feels well. What do you want to do for this patient? 30 seconds. Come up with your plan.
Another 10 hours. And if that's all we got, she's got but not 100, or then you also get procedures. No fruit. Yeah. Flowers. Because they just have like one fill for the lobby.
Okay, table 1. What's one thing that you want to do for this patient?
CBC with this.
Okay, CBC with diff. What are you looking for?
Neutropenia.
Yeah. What's the thing that you're going to calculate?
Absolute neutrophil.
Perfect. They're ANC, absolute neutrophil count. Middle table, what's something else that you want? Yeah, what are you going to look for?
The breath sounds.
Okay, so we're going to do a targeted exam. We'll do palm. What else?
Like an infection source.
So tell me like exactly what you're going to look for as you're doing it. What are you going to check? What are you going to?
Lungs,
Yep.
abdominal pain,
Okay.
tenderness, getting tenderness.
Yep.
Oh, yeah.
Couple other things that we want to make sure to examine.
Especially in cancer patient, like ports,
Yes.
great.
All of their lines. And then, yep, and skin. And then Justin brought up patients usually have issues with nausea, vomiting, eating.
Where we get some irritation, it's super.
Yeah, mucositis. So if mucositis is really bad, you want to make sure they're not having any sort of like dental infection or other thing going on. Perfect. All right, table 3. What else do you guys want to order or do? Okay, UA. Any other labs? Perfect.
If they're totally asymptomatic, are you going to do UA?
It's very easy. Biggest symptom.
Biggest symptom, yes. Correct me if you disagree, Cassandra, but typically, if somebody is neutropenic, it doesn't mean that they won't have symptoms. If they have a UTI and it's not one of the IDSA guidelines to treat, so pregnancy, pre-procedure, if you have no other source and they're crashing, you're probably going to cover and get it anyways. But if somebody doesn't have symptoms, please stop getting UAs in your generic patients because they're expensive. Cultures and antibiotic overuse.
Yeah, we're a good balance for each other because Michelle will tell you the things to do that are cost effective. And I would say this patient should get blood cultures, a UA, and a chest x-ray. Dr. Unterborn, you were saying something about her temperature.
Oh, yeah, so.
Tell me more about that.
Since her temperature is above 100.5, like the definition of a neutropenic fever is you need like 2 blood or temperatures between like over 100.4 within an hour of each other, like an hour apart, or or just a single temp over 101.
Perfect. So excellent. So if your patient is totally asymptomatic, has a slightly elevated temperature, it is totally okay to ask the nurse, could you repeat this in 30 minutes and tell me if it's still elevated, in which case I'll take action on it. Obviously, if they're symptomatic, other vital signs are affected, please don't wait. You need to start some treatment. So perfect. So their temperature has to be elevated. And what's the other cutoff that we use? How do we define neutropenia? Yeah, so the technical definition of neutropenia is an ANC less than 1500. Severe neutropenia is what we often go off of in terms of medicating these patients. Do you know what number that is? Perfect. All right, so nurse pages you 45 minutes later and says her temperature is now 101. So we're gonna get this UA, the blood cultures. As I've said, most people will get a chest x-ray as well, just to rule out any like obvious infections. What do you guys want to do for treatment? Are we gonna just like wait until our blood cultures come back? Let's say her ANC is 10. Yeah, but antibiotics, which ones?
I'll give her daptomycin.
That's a choice.
That is a choice. So what organisms are these patients going to be most susceptible to?
Scary things like Pneumonitis.
Yeah.
And cover with like something.
Perfect. So if you guys think about a patient who is neutropenic, has a blood cancer, is getting a ton of chemotherapy for their initial admission, their GI tract is the place where they'll often have the most breakdown, and that's where we can get translocation of bacteria. So you need to make sure that you're covering at a baseline for gram-negative organisms, and especially if they're in the hospital for a long time, or you have a high prevalence of resistant bacteria, they need to have pseudomonal coverage, because that will be the thing that will kill them fastest. So we're going to start her on some cefepime. And then what about gram-positive coverage? Do you think that we need it in this situation?
Criteria, right? Like they have to be in the septic shock or have like an obvious soft tissue.
Perfect. So I think that we don't take care of blood cancer patients that often. And so when we see them, we're like, give them every antibiotic possible. But truly, they only need gram-negative coverage with pseudomonal coverage if they are hemodynamically stable and do not have an obvious skin or soft tissue infection. Now, if their port looks infected, they have a gnarly cellulitis on their skin somewhere or something else like that, then yes, you can add vancomycin. But as long as they're hemodynamically stable, it's okay to hold off on vanco until we get back culture data to guide that.
I believe pneumonia and mucositis also qualify you for vanco, which is the reason dapto would be a good choice because dapto is not going to be effective with pneumonia.
Yep. And we generally avoid linezolid because it can cause bone marrow suppression past what they already have. So vanco is going to be your go-to. All right, great. So she gets treated with her cefepime. Turns out she maybe did have a UTI, but she's good to go after that. And so let's go down into her care. So she gets a 28-day bone marrow biopsy, which is standard for a patient who's on 7+3 therapy. And she has a complete response. So yay, we did it. Her cancer is cured for now. What do you guys want to do with her now that we've given her 7+3? What's going to be her next step in her treatment, or does she warrant additional treatment? Take about a minute and a half with your teams. Again, use any resource that you want, and then come back and tell me what you want to do.
I will let you guys think about this question. No, for this one,
So apparently our option for it was 360 to have like the response. Actually, I missed you guys.
So the question you guys are solving is, you know, it's happened so far, that's your.
Because you can resolve it. Can't you just, and all can resolve. So, yeah.
Totally.
Yeah. That's what I know.
Yes.
How long has he got for?
so do you think this person is
future.
I feel like I know.
So,
Just started five.
that is generous. This, I mean, without going into like psychiatric prognosis and all that fun stuff, I think it's fair to say that this person is not, I would not use a C word for this person. I would say that there's no signs of disease now, and but I would also tell this person is like, reach your chances of sustaining response, reach your chances of
All right, let's come back together, guys. So this patient had a good outcome after her hospitalization for 7+3, showing a complete response. Table 1, what do you guys want to do for her?
for absolute field count.
Let's say that she's recovered, her counts are all back. She's going to get discharged today, but we have to figure out the next step in her treatment plan. High dose cytarabine, okay. Middle table, what do you want to do?
Before we do our response, can we just clarify this is otherwise healthy?
Yep, otherwise healthy. She's got no other medical problems. This was just her only thing.
Okay.
Perfect. And then last table? Yeah, perfect. So Meryl is using the word consolidation. So she just went through induction therapy, which means we get control of her disease, but now we have to keep her in control of her disease. If we just let her go, her AML would certainly come back, and who knows what would happen if we didn't do anything for her. So we have to provide some sort of consolidation therapy. Table 1 is right. You can do high dose cytarabine, or you can do a bone marrow transplant. So her hematologist is on the bone marrow transplant path. So that's what they signed her up for. Consolidation is, sorry, one more time.
What is it?
So it's keeping her in her disease-free state.
It's like a blanket term for like, yeah, it's like, it's not maintenance, because that's different, but I also think consolidation is like a bridge to something definitive, like, so you induct someone, you make sure you wipe out the disease, and then it's whatever therapy you're doing to keep someone disease-free until it's a definitive cure.
Yeah, because if we took her off of her 7+3 and provided her with no other treatment, her disease would relapse. But she can't be on 7+3 forever, right? Like you can't just be neutropenic in the world on that. So we have to give her something else that's more sustainable to treat her disease. And it can be done through high dose cytarabine or bone marrow transplant. Okay, so her hematologist says she's going to get a bone marrow transplant. Do some research. What are the different kinds of bone marrow transplants we can do? And then what are the pros and cons of each of them? I'm making you guys do a lot of research today because you have to know the questions to ask and where to look for patients who come in like this.
Or like no so what do you guys
I know you need to like draw each line and stuff, and sometimes like you have a actually better have a non-member that's HLA match because there can be some like stuff that goes on.
that is awesome. So Charlie, so that's definitely.
Yeah, so doing like, transplants to like solid organs, it's like not a good thing, because you don't want that to happen, but for like bone marrow malignancy, so etiological malignancy, or any other things, you can help get like rid of some of the chemical fat cells.
Yeah, well, like solid organ,
So
right,
something
like sure it is,
really not like this,
liver,
not a
it's not heart, that like
Right.
the donor is rejected, or the recipient is rejected, you know, heart, that's what, right, that's because the donor is directed. In this case, right,
And
there
then the
is
question
no.
is what is the source of stem cells? Right? It's not that
So now, the donor, it's like, what is all this nonsense?
So you
And then like, what do you find out?
that's
Really,
not.
this is like the thing that's not going to take away from like, you know, like, people, right? It's just like, if someone
To give you hair cells.
right,
But a lot of
the
people don't.
overlap of rejection, like, pretty good there. Sure, it's very, the ideal is like, just like walk out. And just like,
Okay, let's come back together. I'm hearing lots of good teaching.
Basically, so.
So stem cell transplant. You guys will take care of these patients at one point or another, and especially at other institutions. They're admitted to medicine services. So if you end up graduating and going somewhere else, you will see them. What are the different kinds of transplants that we can do? Chat them out.
Auto versus allo.
Yeah. So we have two different kinds, an auto versus an allo transplant. Do you want to tell us the difference between the two?
Yeah, so essentially like bone marrow transplant, you are like destroying your own bone marrow to make place for some sort of rescue cells. And autogenic transplant means you have ahead of time saved your own stem cells to give back to yourself versus the allogenic or allogeneic, whatever it is. So we're using some pulses or external stem cells to rescue.
Yeah. So an allo or an auto transplant means that your own stem cells are harvested. And the purpose of an auto transplant is basically to give you high dose radiation and chemotherapy. So we're going to give you a dose of radiation, a dose of chemo that is so high that you would die if we had no other cells to give you back after your treatment. And so they come from your own body. You get them collected, you go through that process, they infuse them back into you. Allergenic means that it comes from someone else or something else. And so with that one, it's the same idea. You collect cells from someone or something. It can be a relative with HLA matching. You can use umbilical cord blood to be able to do it as well. And so for this case, you collect the cells from someone else. Again, the patient gets high dose chemotherapy and radiation to kill off all of their cells, and then those are infused back in the other person's cells or the umbilical cord cells. What do you guys think might be some of the pros and cons of each of those types of transplant?
Well, I'm sure auto, there's like sometimes you might get for that if you have bad bone marrow, but you always have good bone marrow to give to yourself.
They can collect your stem cells, yeah. So even if you have like a hematologic malignancy, they collect the progenitor cells, and those can be infused back into you.
Is allogenic associated with more increased mortality compared to allogenic?
Yeah, and why do you think an allogeneic stem cell transplant is a little bit more high risk than an auto?
Just
Yeah, what's the risk of putting in someone else's cells into your body? Yeah, rejection, right? Like the immune system does not like things that are not its own. And so anytime you're doing an allo transplant, the risk of rejection, the risk of other complications goes way up compared to an auto. They're both still difficult on the body because you're taking like massive chemotherapy and radiation, but an allogeneic stem cell transplant is just a riskier endeavor. Yeah.
And I'm sorry if the answer is obvious, but then why aren't we always doing it?
Perfect. Yeah, so there's another benefit to an allogeneic stem cell transplant. Anybody have any ideas? So we can give that high dose chemotherapy and radiation to kill off all of the bad cancer cells. But what's another benefit of perhaps using someone else's cells in your body?
You get some like GVH so that it can also kill those like bad cells.
Perfect. So the infusion, I'm seeing a future hematologist here in my vision. So the benefit of doing an allogeneic stem cell transplant is that not only can you give that high dose chemotherapy and radiation, you really pack a punch and kill off everything. You also get some graft versus disease effect. So the other person's immune cells can go off and fight the cancer in your body. But what's the risk there too? So we have graft versus disease, but then we also have graft versus host. Yeah. So that's the con of this type of transplant. And then of course, just finding a source for your cells can also be troublesome for some folks. If they don't have family or siblings, you can't find a matched donor through like the Be the Match registry. And if the center doesn't do cord blood transfusions or transplants, then you might be out of luck in that case. Excellent. Okay, we talked about that. I'll fill it in later for you guys. So she comes in for her transplant. She has an uneventful transplant course. She's discharged on the following medications for immunosuppression and for infection prevention. Nothing crazy there. We will continue on. So she comes back on day plus 42. So 42 days after her stem cell transplant. She has crampy abdominal pain, diarrhea, and she's tired. And she's noticed that she has a little bit of blood in her stool. You'll see her vitals there. So she's pretty tachycardic, she's a little hypotensive. Temperature is 100. For her exam, the pertinent things, she's tacky, she's regular, she's warm and well perfused. She's got some dry mucous membranes. Her lungs are clear. And then for her GI exam, she's tender across her abdomen. She has bowel sounds. There's no rebound, no guarding. And I gave you guys just some basic labs that she got coming in. Questions on that? Okay, so you have this patient coming in post allogeneic stem cell transplant. What's on your differential and what do you want to order to help work this up? Take about 2 minutes with your teams, talk through it, and then we'll come back.
I know one of the, like, doctors folks has like a try. Yeah, so it's super
Certainly going down. That's pretty.
is what?
I'm used to seeing a low, so like, getting down in gravity, I'm like, cool.
Total coach, T-Billy. Don't know what.
Total albumin, total billy, AST, ALT, alk phos.
Okay.
The bottom is from my. Oh, yeah.
I always thought it was the first couple of weeks, what things can I do about it? I like the.
Yeah, CFP is really.
You guys also suspect the GPH, right? So how is that?
I need biopsy, so,
Why was that better? We're all in it, right? But what else?
Yeah, I think teachers are like, CFP or EGDs. We should try that all.
But let's get this first.
There is always
For sure. But the thing I want to point out is that, right, just because they're communication, those
yeah.
equalize and they're also.
more about that.
Yeah, all the conflicts also becoming more.
Okay, let's come back together, guys. So I'll ask each table to give me one item on their differential and the corresponding test you'd order to work it up. Let's start here with table 3. So what would be one thing on your differential for this particular patient? Okay, so graft versus host disease, GVHD, and then of what organ?
The colon.
Yeah, the gut. And what's the test that you would do to work that up? Yeah, with? Perfect. All right, middle table, what's another thing that could be on the differential for this patient?
Just have like the general infectious diarrheas.
Yeah, infectious
Making sure
diarrhea.
we're not missing something obvious.
What would you order to rule that out? So stool
Yeah.
culture, PCR,
All those things.
and then same thing. What are you gonna look for on your biopsy? Great. So you can also get the biopsy to rule out things like CMV or other viral causes of colitis. Table 1, what's another thing on this patient's differential? Yeah, medication side effect.
Metabolitis specifically, but there's others.
Yeah, great. These patients get discharged on a million medications, so it could definitely be something like that.
What about, vaso-occlusive disease?
Yeah, that's a great SOS. Sinusoidal obstructive syndrome is something that can happen. Maybe that's not what you're getting at, but I'll give it to you. For post-allergenic stem cell transplants, they can get like clotting in their liver that can cause their allergies to go up. Usually that diarrhea is not what we normally see, but definitely could be a differential if our allergies are a tiny bit elevated. Any other things that you guys should put on your differential?
Ischemia.
Yeah. So ischemia, ischemic colitis, mesenteric colitis, great. Taking care of cancer patients is great because not only do they have all of the normal medicine stuff that can happen, but they have all of these other things that can happen because of their disease, their treatment, or their medications. And so for this particular patient, she gets all of these things ordered. Her infectious workup is negative, and when you call GI, they come by and they biopsy her, and turns out she has GVHD of the gut. And so now that we know that, it's a diagnosis of exclusion, so you have to make sure she's not infected with CMV, with C. diff, anything else. We won't get into like the grading and all of that, but generally speaking, how do you guys want to treat someone who has graft versus host disease? Yeah, steroids. And for her, if it's just localized to her gut, what's an option that we could give her? I heard someone say it. Yeah, budesonide. So it's local to the gut, doesn't get absorbed systemically. She's already on a bunch of immunosuppressing medications and is in the acute transplant time period. So she's already still, immunosuppressed. So giving her systemic steroids is not great if we can help it. So yeah, you could do budesonide. These patients can also get things like raloxifene, it's a JAK inhibitor, or even go for extracorporeal photopheresis as well. So lots of different things that we can do for them, but for your knowledge, just knowing about steroids is the most important thing. Great. I'll pause here and let Abdi provide some teaching about this particular case before we get to the next one.
Yeah, this is great. I guess one thing with the particular case, I know a lot of you guys already called me about the question I always get is like, hey, when are you gonna when should you express an image? And the answer is like rare. The reasons rarely is because at least in like the solid tumor setting, right? Someone who's coming in with like pancreatic cancer, lung cancer, with like a bunch of like platinum therapy, or it's got some lymphatic and all kind of like 10 platelets in their system. And you're asking like where the reason I usually say no is because one, it's expected. Like most of these patients, you look back at the records, they're at cycle 5, sometimes we like cycle 2 and cycle 5, they have the exact same episode. It might not have been like hospital order, but it's similar. And we expected because we expected it to happen like 10 to 40 days after like platinum therapy or cytokine or whatever else that might give them. Not all chemo will do that, but there are certainly some that will, like platinum as well, cytokine as well. Even it's like 5-FU phase will do that. And so with Neupogen, the data shows that it has no mortality benefit, it's recommended it, and the length of stay benefit is a day. So like on average, what's not a hospital, a day faster. So why not do it anyways, right? One reason we might not do it anyways is because if you give, so let's say there's someone with pancreatic cancer, and you've got like on a 6-8 cycle course, right? And they're coming in here between cycle 3 and cycle 4, and they've got 2 cycles left, right? They're like literally 5 days away from their cycle. So if you go to the hospital, you give them the Neupogen shots today, they charge tomorrow, sorry, 4 days. I basically now, instead of they're going there for total catastrophe. So what's going to happen is we rev up their regenerative cells, which means CSF, right? So they're now this like high division, high mitotic state, the same as the cancer cell. So now my chemo, it's going to have the cancer and So this has happened before. There's like the only oncology MNOs I ever saw in residency were the ones where it's just this is kind of what happened where we gave someone Neupogen right before chemo, and they got worse. It, like the things like bombed out even more after the next cycle. So it's one of those things we try to prevent. Not that we won't prescribe it, but like if someone's like on the way to the ICU, you're calling me. Yeah, that's probably time to Neupogen, and also plan it like this. So that's good for all of them. For GVHD, yeah, this is like one of those things. I mean, unless you're on a BMP service, it's rare to see this kind of patient. But this is a great case to kind of step through. I guess like one thing to point out is the triad that someone mentioned was like definitely for skin, liver, colon, skin, liver, GI tract. That's like usually classic. I don't know if you know why those theories are preferentially affected. They are. And then like one thing to point out is there's acute versus chronic GVHD. So even if someone's like literally 3, 4, 5 months past their transplant to show this rotation, you have to always consider GVHD.
So what is that time course like that you typically see acute and then a chronic is like after a year or actually?
The research cutoff is 100 days. Why is 100 days? Just because you know, because life.
Yeah.
But 100 days is kind of the cutoff that's like used in the field. I mean, with chronic GVHD, like it tends to be more skin for some reason. You can obviously change this. We draw the line at 100 days and 400 days, like it goes twice a year. It's like visceral organs mostly. After 100 days, like skin mostly. Yeah. Ask me in 6 months after I do
Yeah, it's like an arbitrary sort of cutoff. Yeah, and that's usually, they get like another bone marrow biopsy at 100 days usually, and so lots of things just happen around that time.
One thing, just someone on the question of like why do we do it, or what's the benefit, GVHD, what's that about? One thing that's kind of interesting to understand is that it's very, the ideal scenario in this whole situation is that you transplant someone and they're cured with no side effects, and they go on to live their best life forever, right? The absolute worst is the opposite, like there's still leukemia in their blood and they've got all these symptoms. Usually there's something like that, right? Usually you're gonna get like a little, the goal is to get like GPL versus leukemia with like minimal GVHD. Getting no GVHD, like you don't really,
Yeah.
it's kind of like a big deal. But that's kind of the expectation.
Any questions so far on this particular patient's case? So we reviewed neutropenic fever definitions, we reviewed GVHD definitions. I have a couple more cases that we can do if you want, but I also am aware that we're coming pretty short in time. So if anybody has to go for patient care stuff, you want to go eat your lunch, it's fine. If anybody wants to stay, I'm happy to go through the rest of the cases. We will probably not get through all of them. We probably have time for just one more short one. Okay. Yeah. For anybody that wants to stay, we can do one more quick one. So next case. Next case is a 67-year-old male who has a history of multiple myeloma. He's on BRD. He also has hypertension, diabetes, hyperlipidemia, and he's admitted for chest pain. You can see his vitals there, his initial labs. And as you're interviewing him, getting ready to take him to the floor, he's still having chest pain on admission. His EKG has no ST segment elevations. He has some mild T-wave inversions and V4 through V6, but otherwise looks the same as his previous EKG. So what do you want to do for him? We're a smaller group now. You guys can just shout out what you want to do for this particular patient. Yeah, so how often do you want to get them?
Every 6 hours.
Yeah, and what's the diagnosis that you're worried about, David?
ACS.
Yeah, So we're making it very obvious. We are worried about ACS in this particular patient. He's got lots of risk factors. So we're gonna get an EKG every 6 hours. What else do you guys want to do? Chest X-ray? Why a chest X-ray? Yeah. Rule out any other cause of possible chest pain. Okay. Yep, we're gonna get tropes.
Can you just describe it as being a little bit more, is it at rest, is it deep breath?
It's your classic cardiac chest pain. Worse with exertion, better when he's resting, substernal. He feels like it's sort of been coming on and off these last couple months, but today it was persistent, so he came in. Yeah, and who are you gonna call? Yeah, so we're gonna treat him for ACS, for an NSTEMI, right? He has elevated trope, some EKG changes, but no ST segment elevations. So he gets the aspirin, the statin, a heparin drip. And most importantly, we're calling cardiology to say, hey, I think you guys got to cath this guy.
And just, you know, Q6 for the EKG is okay if you're like slow trending, you're not that concerned about somebody. I probably would do more than Q6, especially in the acute stage. So frequently, if it's an NSTEMI, you might do like Q2 to 3. But 6 is more if you're not as concerned.
Okay. So let's say cardiology comes down, they see him, they're like, wow, this guy has a really convincing story. We're going to take him to the cath lab. And so he's in the cath lab right now with cardiology, getting worked up. But you're working through the rest of your note because you know he's going to come back. So he's on VRD for his chemotherapy regimen. So what is that? What are the drugs? And do you care about the fact that he's on VRD? Are you going to call anybody, not call anybody? What do you want to do with it? Yeah. Backwards.
Yeah, okay. Cool. Yes.
Bortezomib, I can't spell these things. And then dexamethasone. And the reason why I picked this particular case is that Revlimid is a pill that people take. So they might come into the infusion center and get their bortezomib as an infusion, but then at home, they're taking dexamethasone and Revlimid or lenalidomide. So you will see patients who are on it. Someone tell me, what are some of the adverse effects of lenalidomide? So I think about peripheral neuropathy more with bortezomib. Lenalidomide has some particular side effects. Can cause some diarrhea, but think about why this guy's coming into the hospital. So it can cause, not a cardiomyopathy, but it can cause arterial and venous clotting. So for this guy who's now had an MI admitted to the hospital, what do you guys want to do with his pill? Yeah, so we got to hold it, right? And then are you just going to take him off of it, discharge him in 3 days once his cath is done and all that? Or what are you going to do? Yeah, and so you're going to say, hey, this guy's admitted with an NSTEMI. He's on VRD. And I think that he'll need a change in his treatment going forward because he's now had ACS on lenalidomide. I had a patient like this. That's what happened. I changed his therapy after he had an MI. I forget what they changed it to, but he got taken off of lenalidomide for this reason. So just think about that if you ever see a patient who's on that. Okay, I keep pushing time. You guys want to try and fit in one more?
Yeah, even if people are spread out, you probably also eat at the same time because you can easily get 6 feet apart.
Yeah, you guys want to eat.
You'd have to be like the ends of your tables, not near each other at all.
Yeah.
Okay, last case. We have a 70-year-old guy. He has a history of COPD, hypertension. He's on treatment for non-small cell lung cancer. He has a tumor in his right upper lobe. The size is estimated at 0.9 centimeters, and there were no abnormal lymph nodes on his scan. And so in oncology, we grade people based on the TNM staging system, so tumor, node, and metastases. So look up what you think his TNM stage is. And if you can find any data on his estimated survival based on this stage. And again, you guys can just shout out when you think you have an answer.
And then the MRS 0.
Yes,
1A.
1A. Okay, any thoughts about overall survival for a 1A non-small cell lung cancer? I'm getting a thumbs up. Give me a number estimate.
80%.
90? Okay, yeah, I'll do Price is Right rules. So just talk about TNM staging. So the way that lung cancer works is that if they have a single tumor in one part of their lung with no involved lymph nodes, that's generally going to be a stage 1. The next thing that we look for is, are there lymph nodes on the same side as the tumor? The thing that will progress them farther is, do they have lymph nodes at a different level? So like, you know, if it's supraclavicular versus hilar, and then do they have lymph nodes that are across their chest on the other side of where their cancer is? And then lastly, it's like, do they have any distant metastases somewhere else, brain, liver, whatever. So that's the sort of thing that guides TNM staging. And I think that, again, something that we're not that good at in terms of recognizing is that if you have a T1 tumor that is pretty small, your estimated survival for somebody with a 0.1 to 1 centimeter tumor is actually 91%. So that's very good. And I think that often we get into the habit of being like, oh my God, this person has cancer. They're basically dead. Why are we bothering to treat them? Or why are they here in the hospital? So just know that, you know, if we catch cancer early, there is a good chance at cure for some patients. So we talked about this part. So for him, he really should just get that cancer cut out, but thoracic surgery sees him and says, he's not a surgical candidate given his age, his comorbidities of his COPD, it's really bad. So he will not get surgery and instead will get radiation therapy. He gets admitted back to you 8 weeks after radiation therapy. He's in the ER. He has shortness of breath, cough, fatigue. You can see his vitals there. He's now hypoxic. And I'll give you some points of his exam. And so shout out, what's on your differential for this patient? What are we going to order? Shall I get into that to work him up? And how are you going to make final diagnosis for this guy? Yeah, PE, okay.
And we can also get paid from the radiation therapy itself,
Mhm.
and it's after it's less than.
Yeah. So PE on our differential, what test are we going to order to roll that in or out? Yeah, so he is hypoxic, he is tachycardic, he has an active malignancy, so getting a CTPE and skipping the D-dimer is probably what you would do. What else is on your differential?
COPD exacerbation.
Yeah, so he has terrible COPD. Is it a COPD exacerbation? What's going to help you make that diagnosis, David?
Chest X-ray. And then whether it improves with.
Yeah, so really your history, right? So you're thinking about what's the definition of a COPD exacerbations? They have increased dyspnea, increased cough, increased sputum production. That's you know, in the setting of known COPD. And so for him, I think it's very reasonable. You could treat him and say, is he going to get better or not? Let's say he's treated, he doesn't get better. He gets a little better, then he gets worse again. What else is on your differential? Pulmonary fibrosis from what? So is this an effect of his radiation therapy? Do we have a diagnostic test for that?
Well, you can do lung function tests.
Yeah.
You can just look at it and just. Want some normal CT or one special CT. There's a special CT.
Yeah.
High resolution.
Yeah, so you get a high res. if I can spell, resolution. Or CTILD is sometimes the protocol, if like your hospital has that. What are other things this guy can have? He's old, he smoked forever, he has hypertension. Yeah, it could be another tumor.
It had obstruction. But that's unlikely.
And that might.
Yeah, so does he have some sort of like cardiac disease? Maybe he has heart failure. So the point of this case is to sort of think through how radiation pneumonitis might present, and to realize that there are tons of other things that a patient could face that could present very similarly. So he has crackles, he has cough, he's short of breath, some edema, he's, has malaise and is losing weight maybe. That could be radiation pneumonitis, that could be a CDP exacerbation, that could be heart failure. And so you have to order all those tests to say his EF looks fine, his PFTs are stable, or if if they look like there's a diffusion limitation, you could say, oh, maybe he has some radiation pneumonitis that's there. But otherwise, you can't make the diagnosis of radiation pneumonitis until you've sort of crossed off everything else. And so radiation pneumonitis falls into two categories: acute, which is in the 4 to 12 weeks after treatment, or chronic, which is like months later. And the way that we treat these patients is 40 to 60 milligrams a day of prednisone. And it's a very, very slow taper over like 3 to 4 weeks. And so if the patient comes in and you're like, well, they're wheezing and they have increased cough and sputum, I'm going to treat them for COPD, and they get better for a day or two and then get worse again, it's probably that prednisone that was helping them, and not really the azithromycin. And therefore, they might need to be on that longer course of steroids. Don't forget your PJP prophylaxis, because you're going to be on it for a long time. But that is the way that we can treat it. The thing that you can see on chest x-ray is that the area that was radiated will have these straight lines going through it. And that's the fibrosis from their radiation, or the damage from the radiation. And so if they have these like straight lines that are not consistent anywhere else in their lung fields, then you could say, I think that this is radiation pneumonitis as opposed to edema from heart failure or whatever else. You can see it on chest x-ray if it's pronounced enough, or CT scan if they get that too. So, but there's no one definitive test that will say, oh, this is radiation pneumonitis, like, open and closed case.
We had a few patients like this in the last week.
Mhm.
And the big question was, like, if you don't want to give them steroids if they have an infection.
Yeah.
So it was always like pneumonia versus.
Yep.
Like checkpoint pneumonitis, radiation pneumonitis.
Yeah. Yeah, because even the therapy for checkpoint inhibitor toxicities is much higher. It's like 1,000 milligrams a day, or like something super high for checkpoint inhibitor pneumonitis. And so it is very important to make sure they're not infected before you're giving them a bunch of immunosuppression. But it can definitely be a tricky situation where you maybe treat them for infection first and see if they're getting better. And if they're not, then you're like, maybe it's not infection, maybe it's some sort of pneumonitis from their treatment. Okay, I think that was all the cases that I had for you today. In classic fashion, too many to get through in our amount of time. But thanks for participating. Let me know if you guys like this. We can definitely do more mini cases about other stuff too. But I figure it's a good way to sort of go through different conditions quickly. Tomorrow you have M&M with Michelle. Wednesday, if anybody has a cold case they want to present, let me know. Otherwise, we'll just do another case conference. And then Thursday, we have clinical reasoning with Dr. Amos. And Friday is trivia and outcomes. So prize on Friday for trivia. Wow, you'll be at your shelf. No prize. I know. Good luck on your shelf on Friday.
This is AMA.